and traditional socket prostheses for transfemoral amputees. Please.
Please, thank you. Ladies and gentlemen, colleagues and friends, my name is Eva Häggström. I work as a CPO, or certified prosthetist, in Gothenburg. I work lower extremity, so I have both socket prosthesis and osseointegrated patients. I have a few slides with unpublished results, and I will please ask the audience, don't take any pictures of those. But it will say unpublished result in the upper right corner. So the conditions are a bit different for different amputees. And here are some of the patients I've been working with in Gothenburg. And when the doctors send them home, they say, you will have a prosthesis and everything will be all right. It could be hard, but sometimes it's working. So the differences with the two prostheses is, of course, the attachment. If you have a socket prosthesis, you have to go all the way up. It has to be tight so the patient will get balance to be able to walk and do all the things they do at their everyday life. And if you have a socket, you usually need to learn a way how to walk so you understand the components, because you can't really feel where you put your feet. The volume will change if you change your weight, if you gain or lose weight, etc. You will get pain and blisters when you walk far distances, usually. With the osseointegrated prosthesis, it takes a few seconds to take it on and off, and it will always be in the right position, of course. It means 2 surgeries for the patients, and between the surgeries, it's a healing period. In the method we use, it's 6 months, and then the patient can use a socket prosthesis. And when the wound is healed after the second surgery, we start with a short training prosthesis and gradually loading. The patient can load more and more gradually to build a stronger bone. Some of the things we talked about yesterday was the penetration area. You need good surgery, of course, but we can help nature a little bit with the soft tissue support. And here is only a thin layer of skin, and then it's the femur, actually. And I do a soft tissue support in soft silicone to get a small pressure, which stabilizes the skin in this area. The long prosthesis, usually 12 weeks after the second surgery. I call it a rehabilitation prosthesis. Only 20 kilos, and the patient have to use 2 crutches for at least 3 months. And when the patient can load more and more, we need to do some additional adjustments. And I use more complex components, usually 1 year after the second surgery. And about that time, the patient are back at the same activity as before the treatment, usually. But then moving forward. Cosmetic cover, the female are very happy to be wearing some tight clothing. And the patient is in Gothenburg are treated at the Center of Orthopedic Osseointegration. We have 100 treated patients in Gothenburg, 150 on the lower extremity, about 35 on the upper. And the patient mostly is from Sweden, but also Norway and Spain and some other countries. And we have some other centers over the world. UK, the center started patients 97, I believe. And then we have some new centers. I forgot Melbourne. Okay. And this is some unpublished result. And then I was looking at the health economic for prosthetics. And we were looking at the cost for the maintenance of the prosthesis. So it's new prosthesis, adjustments, follow-up, etc., and the number of visits. We have in the socket group on 36 patients and 20 patients in the OI group, and the year between 83 to 2008. And the cost for the maintenance of the prosthesis were almost the same. The patient group are almost in the same activity level, but the visits are significant less for the OI group. The S group have 7 visits per year, and the OI group 3 visits. It's not so many studies writing about this, but we find a few, and they have comparable results about the visits. Some other conclusion about the OI prosthesis. Laurent Fossard with high functional level of locomotion, and Kerstin's study from 2008, an increased prosthetic use and improved quality of life. Here are some other unpublished results on osteoperception. I was testing vibration under the healthy foot and the prosthetic foot. 17 patients in the OI group. I tested them before the treatment and 2 years after, the same persons. And also 17 patients with socket prosthesis. And the conclusion were improved detection of vibration in higher frequencies after 2 years. Sitting, here's another study of Kerstin. I only say transfemoral amputation. What would you prefer? Socket, no socket? Sitting low, no problem. Hip range of motion, no problem. Well, I don't have any prosthesis. I can't do this. So as I see it, it's different attachment. 2 surgeries. Surgery is always a risk. The rehabilitation, long, yes. Freedom, no master socket. One patient said his socket were his master. He always had to consider the prosthesis and planning his life. And if you fall, you can risk more. Osteoperception, maybe it could be more safe for the patient. And actually, we believe a higher level of active everyday life. Here's one man's first step with his bilateral prosthesis. He's really active today, though. Thank you.
Okay, I think we do like this because there is now a number of presentations from the Gothenburg group that we collect all of those as a discussion after them. So you will be back, Eva. Thanks for now.